Good morning. That was exciting.
Thank you all for joining. We are going to record this session. My name is Sophia Chansey. I'm the president-elect for the Northern California HIMSS, and it is my pleasure to welcome all of you to today's discussion on integrating the virtual and physical care settings. We have a fantastic panel today, actually an international panel. I think, Ari, you are somewhere in Europe, is that right? Fantastic. So coming off the back of HIMSS 2021, where this topic was ever present, and looking at the news and the surge of the Delta variant, I think the conversation and the topic we're having today is certainly relevant. I am very much looking forward to hearing the perspectives of our speakers on the hybrid model, so physical practice and digital solutions, as well as digital first model, as well as technology innovation and tools for providers and clinicians. Before we get started with our topics, I would love to ask our speakers to introduce themselves. Jukka, why don't we start with you?
Oh, thank you, Sophia. Hi, everybody. My name is Jukka Valkonen, and I'm the co-founder and chief health officer for Giseki Health. We are about 5 years new and have become the largest AI-enabled digital-first primary care in the United States. Happy to be here. Thank you.
Thank you. Sanjaya.
Yeah, good morning. Thanks so much for the opportunity to be here. My name is Sanjay Schweig, and I am the founder and director of the California Center for Functional Medicine. I've been working in integrative and functional medicine for over 20 years, and just really having a lot of fun pushing the boundaries in terms of what we can do with chronic illness management, merging care team and technology. So it's a pleasure to be here. Thanks.
Thank you. And last but not least, Ari.
Hey, thank you so much for having me. I'm Ari Tulla, CEO and co-founder at a precision nutrition company, Elo Health. Prior to Elo, I spent about a decade running two companies, founded a company called Better Doctor in the data space, and then run a company called Quest Analytics as CEO in network management space. And before that, I spent a decade in tech at Nokia and building video games of all things.
Fantastic. Thank you all for the introductions. Before we jump into our topic, a little bit of logistics for our attendees. Thank you for being here. You will notice that your microphones are muted at the moment. If you have comments or questions throughout our conversation, please put them into the chat, and I and the speakers will be able to see those questions and take answers during our Q&A at the end. If I can also direct you to our event page on LinkedIn, you will have an opportunity to continue the conversation on our event page. I've started us by posting an initial comment there. If you have additional comments, additional thoughts on our discussion today, please go ahead and use the event page on LinkedIn for HIMSS Northern California, and I will post a link to that in the chat to continue the conversation. And with that, I'd like to go ahead and start. I know that based on research that Jukka has conducted over the years, including interviewing over 1,000 physicians, he's identified what he calls the provider's hierarchy of needs. So what we're going to do is base our discussion on that provider's hierarchy of needs. And the first thing that was identified is time, the gift of time and the headspace. So providers need time. How can digital solutions and virtual experiences provide that gift of time and the headspace, if you were, for providers who are already too busy? Sanjaya, given you have both you utilize the hybrid model, both the physical practice and digital solutions, I'd love to hear from you first.
Great, yeah, thank you. Yeah, super important question. We'll be diving into a lot of topics today, but as technology and as healthcare has transitioned over the last year and a half, 2 years, but really over the last 10 to 15 years with the move into electronic health record systems and the overlay of technology, for many it's been difficult. And in some ways it can be helpful, but in some ways we find ourselves working really hard to check the boxes. And the EHR systems are usually built for billing and for the financial management side, as well as meaningful use, making sure that we're targeting the metrics that need to be targeted, but they frequently miss the experience of the doctor and the patient and end up making it somewhat burdensome. And so our transition this last year was really interesting. The last couple of years, really now, time's flying by. We were really in a hybrid situation pre-COVID, meaning deeply embedded with our EHR, as well as a whole host of technology solutions. And we had actually, all of our staff was working from home. And so we had a physical footprint. We had a brick and mortar clinic, but it was a very sort of a micro clinic. And once COVID really started ramping up in February and March of 2020, it was very easy for us actually to just flip a switch and go from that hybrid model of some visits being virtual, some visits being physical, to a 100% virtual footprint. And we were leaning and have been leaning heavily on a variety of different technology platforms, right? The EMR, our website, which is built on HubSpot, CRMs like Infusionsoft and HubSpot, learning management system where we put a ton of our content for the patients, things like Slack, like Dropbox, like Google Drive, texting platforms, data visualization dashboards, pulling in wearable data. And so it has been a pretty fun and fast-moving iteration and evolution over the last couple of years. A lot of it we had a foundation for, so I feel really grateful and lucky. On the one hand, we didn't have to reinvent ourselves. We didn't have to shut down. Really, we never saw a drop in business. If anything, and it picked up, and there was more demand for the care that we were offering. So, a lot of gratitude and appreciation for our staff and our team, and for our sort of foresight of what we had been building. But again, it really pushed us quickly in the last couple of years. And there's growing pains as we can jump into, but I'll pause there, let some others jump in.
Thank you so much. Yuko, from a digital first perspective, what's your view?
Yeah, I think about this a lot. When we started Jiseki, the question that we had was, will we go with bricks and mortar? And if so, at what point? We set out to somewhat fill a gap that we saw in primary care around whole person. So including the social determinants that are necessary. So when the patient comes in to see the primary care and they talk about, I'm not sleeping well, or I have anxiety, or things like that. And then, whether the doctor or the nurse, asks, why is that? And it might be because of a situational crisis, like I lost my job, or I've got a baby on the way, or I'm being evicted, or I can't pay the rent, or whatever else it is. That's not necessarily a medical problem. And so we found that the bricks and mortar, they're not really equipped to handle the patient as a whole. They're much better equipped, for a lot of the mundane things that are out there. We also saw that with bricks and mortar, that then you're entering into leases, things like that, and that there could be a multi-year payback period, up to sometimes 10 years, depending on where you're at. So we jumped in 100% digital first, right from the get-go. But what we had to do was really look at that workflow. And as we know, with the EMRs, they cause a polarizing effect. And the last thing we wanted to do was to do what some health systems do, where they have to hire scribes to do the data entry, so that the provider can actually have a meaningful conversation with the patient. So that's where the natural language processing and the AI, they came in. And so we're at a point now where our natural language processing and the AI can handle up to about 70 to 75% of the encounters with the patient. And then by doing that, then we're meta tagging the data so that when a clinician does sign on to our EMR, they actually have a fairly strong composite view of the patient and the patient needs, such as finances, housing, food, childcare, along with maybe chronic or even acute exacerbations of a chronic condition in that sense. So we've proven out that having a digital first medical practice actually is very relevant. Our patients have never, questioned that why don't you have a bricks and mortar, or can I come into the office? The office is that virtual sense. And as far as we know, we were the first healthcare company in the world that was able to support HIPAA compliant session persistence between SMS, voice, and video. So even if the encounter begins with text, our clinicians can easily switch over to voice and then also to video from that. So everything is from a synchronous encounter perspective, we can easily support that. But then also the nice thing about it is that if you're texting with a patient, they might go off and do other things. They might, take their kid to school, or they might go shopping or something like that, and they'll just pick the conversation up later on. And that works out really great also for the person, the operator on our end, because then they don't have to feel like they're have to be constantly engaged in a synchronous encounter with the patient.
Thank you. Ari, as an innovator and creator of digital solutions and tools for providers, what are your insights on having providers having the headspace and the gift of time to do their job?
I think Jukka and Sanjay did tremendous work on kind of summarizing two different perspectives. And I don't think I have a huge amount to add, but I think one point that is really relevant today is that we've been moving from kind of the physical setting to the telemedicine virtual setting by necessity of the COVID. And I think both Jukka and Sanjay are, you guys are the leading innovators in that modality and the movement. And I think we have 500,000 providers who have mightily struggled doing it. And they're still, I think, struggling. There is a number of people who've been exiting healthcare, doctors leaving early retirement because they just didn't see meaningful enough to be on a Zoom setting or in a telemedicine setting. So that's a really big area, I think, that needs to be somehow addressed, I think. But the process of automation, I think, speech to dictation is a very big thing, as Jukka said, and Sanjay talked about bringing in the data about the body, home monitoring, wearable devices. I mean, those are some of the areas that I think are going to make a big difference. And the idea of being able to tag the information, make it meaningful, make it somehow understandable by the computer, by the AI, by the machine learning. I think that is going to be the gift of time that the providers might not know today. But I think in the next 5 years or even less, there will be a time when the provider, the doctor, can look at the patient in the eye, might be over the Zoom or whatnot, or virtual reality, or in a physical setting, and really talk to them as a person without need to, look at the EMR, the computer. And we as patients, we don't like the experience where we basically are seeing a doctor typing notes all day long, not addressing us as a person in a need of a human contact. So that in my mind is the gift of time that the tech is giving today and will be giving a whole lot more in the next 5 to 10 years.
Thank you for that perspective. As I think all three of you mentioned, there are never-ending pieces of technology that the providers are looking at. So there are new apps, there are EHRs, EMRs, there's paper still. So the next question that comes is, so what comes off the provider's plate with all of the with all of the tech and the paper and the apps and things they need to type in, how can the providers, both fully digital and those that are in a hybrid mode, how can they manage this full plate of technology? Sanjaya, do you have a perspective?
Yeah, I think it's a super important question, and it's a question that I toy with, minute by minute, hour by hour, day by day, right? It kind of comes in waves, and there's times when my experience of my work is one of ease and of joy and of excitement and inspiration, and obviously that's the moment we all look for and want, and that when you're in the flow and just everything feels fun and easy. And there's also a lot of times when it feels like a slog, and it feels like, gosh, I don't know how I'm going to get back in there and do those last remaining 40 tasks that I have to do, respond to the XYZ message and, refill the prescriptions and check off the labs. And so it really has been an evolution on my end. I came up through my medical career, went to college at UC Berkeley, med school at UC Irvine, and residency at the UCSF Santa Rosa Family Practice Program. And we were always trained kind of like do it yourself, right? There was minimal staff. It was a community care clinic. And if you wanted a fax sent, you sent the fax. And if you wanted something checked in a chart, you checked the chart. And so I always had this sense I had to do it all myself. And so it really has been a learning experience in terms of learning to delegate both to people as well as learning to delegate to technology, and having that ease of the different technology pieces that can be really assistive and are growing more and more effective. But I've really come to appreciate this idea of that everybody should be working to their highest ability at all times, right? So it doesn't make sense for a provider, who's kind of the brains of the system, making the high level decisions, for them to be burdened with the tasks that could be offloaded to somebody else. And so what I tell my staff as well, if we have a MD level provider or DO, or we have a PA, NP, or we have a health coach or a nutritionist or an admin, maybe a lot of our admin are very smart people who have like public health degrees or have like other. So I'm really always asking people like, hey, be creative, like think about, what is working and what stuff you could actually offload to somebody who would be happy doing that task, right? So what we've developed is this really exciting, both high touch, meaning we have a lot of people involved, as well as high tech offering. And so it's this merger that I'm really passionate about. And I think on our end, the people side is actually really, really important, right? So all the mid-levels and the nutrition coach, we really are trying to build this fabric of support from a high touch point of view, and again mesh that with the technology. But the technology, I think, has to become kind of invisible, right? I don't want people feeling like the technology is front and center and is blocking them or is confusing them. I want it in the background. I want the AI and the ML to be providing those insights to us over time, and kind of pulling stuff up that needs to be paid attention to, so that the provider also is not burdened by sifting through data. And to be honest with you, we're not there yet, right? We're still like glaring at spreadsheets and looking at different levels of data visualization and presentation. But when it comes together and you get these really beautiful data viz pieces that you can just glance at and get insights that move the needle, that move the experience, or that enliven or enrich the experience, that's the part that I start getting super excited about and jazzed up about. So
thank you. You as a digital first provider, how do you manage that?
Yeah, definitely echo a lot what Sunja said there, where for us, we have very high touch, what I call like white glove concierges, and they support our entire patient population in all 50 states. And so that at no point does a patient feel like they can't, interact with a human being, and really have a meaningful interaction with them. I almost kind of think of them as like high touch account managers, but the account are their patients, in that sense. That also then alleviates a burden from the clinical staff, because then a lot of things are kind of mundane in that sense, that can be handled by the concierge. And then when they need to consult with a clinician, then they can loop in. What we also did with the AI is that for mental health, once a patient is discharged from active therapy with a therapist, the AI then takes over, and we let them know that they're going to have a daily conversation with a piece of software, and she is sentient. So she'll prompt me automatically, maybe in the morning or something like that. We don't set the timer. Hi, Yuka, how you doing? How'd you sleep last night? Did you have any weird dreams? Whatever, it's a conversation. She's learned how to use emojis on her own. The patients taught her that, in there, which is really cool. Scary, but cool. But then also there's enough intelligence there that, let's say it's 4:30 in the afternoon, and she's having a conversation with me, and I text back that, oh, I wish it would all end. Well, she's not going to nuance that. Does that mean that just the day would end, or my crappy day would end, or something else should end? So, then there's a very somewhat elegant transition over to a human to let them know to, hey, you might as well check in on Yuka. And it was like, oh, he was just talking about that his day would end. It's been a long day. So, to Sinja's point, that the AI and the machine learning and the natural language processing all has to, get to a point of maturity, that it can have these type of relevant encounters, there. The other piece too that we put a lot of thought into, and this is it's an evolving science on our part, is from an assessment perspective, what's the right number of questions to ask somebody via text, so that they hang with you and they answer the questions, and that they don't have kind of like question fatigue in there. So for example, there's the PHQ-2, which is the 2 questions of the PHQ-9. So instead of you starting out with a PHQ-9 and bombarding with patient with that, especially if they're not feeling that well, or they might be depressed or something like that, start out with the 2. So you can apply that type of logic for UTI. Like, what are the 1, 2, 3 most relevant questions, that you might want to ask? So when a patient wakes up in the morning and it hurts to pee, that you can ask those, questions, and, kind of make some inferences from that, which then is all part of the conversation. And then it comes over into the cockpit, if you will. So whether it's a nurse practitioner, a PA, or an MD, then they see what has been the conversation so far with the patient in there. So that's how we try and create, headspace for both our clinical and non-clinical staff, is looking at roles and responsibilities, but then also how do we improve the AI and the machine learning around that. From my perspective, I think that apps are an interference, because there's app fatigue out there, and we did a lot of research into the hype cycle of apps and how quickly they become irrelevant out there. If you have an app that is maybe connected to a continuous glucose monitor because you have type 1 diabetes, that app is then very relevant for you. But other apps, whether they're for activity monitoring or food, nutrition, whatever else, it's always fighting the hype cycle. So that's why, we decided to engage the patient in a conversation via text and natural language processing that way.
Thank you for that perspective. Ari, as you develop tools for providers, hearing this perspective and feedback, as you develop tools, what do you take into consideration, or do you take into consideration the provider's burden with existing technology?
I think first, I think the point on what Jukka said about the apps, and I think I've been working on about 15,000 apps in my lifetime in different places. I was running the app studios at Nokia that was developing the first apps for many of the big media companies, and including also Skype, and we worked on the Facebook app and stuff like that early on. And we saw that early on when the first apps came in that, some of them people got addicted to. And we, of course, know now that, mobile smartphones are probably the most addictive device that ever come to see by man. And I think they are a big problem in everyday life today. And I don't know what we will do about that. But again, there's this fatigue where there are too many apps. People normally use about 10 apps the most. And, the best apps, I think, are more ambient in nature, that are tracking behind the scenes and then only letting you know if something goes wrong. And that, in my mind, is the fundamental point that I think, if the question is that what to take away or what to give up, I think in the society and healthcare today, we can look at the macro. United Healthcare having 50 million people, they don't know how to match those people. They call them members with the right provider. In a case of Kaiser, 9 million California members, they really don't know that either. They don't have a good way of matching the right person. Then we go to Sanjay, you have maybe a few thousand members or patients or customers. And I think the dilemma here is that you have these health warriors who are worrying about the health, and they will be the first who will call you and connect with the provider. They will ask for the help. And then you have many people who are getting sick without acknowledging anyone in the system. So if I'm a provider, and if I want to make an impact and I mean, like we all know, all the doctors, all the providers, nurses, they are there because they love helping people. They love helping people live better lives. They love to, turn an illness around. That's why they do the work, and they are deeply in depth often by doing the studies and so forth. So I think in my mind, if I'm a provider and I could always work with the right pace and the right time, I would be pretty happy about that. And that, I think, is something that tech can do. And both Sanjay and Jukka talked about how that could happen. It could be a triage by a text, a triage by AI, triage by home monitoring, and then maybe having the different levels of care handled by different people. Today, we are burdening the MDs and the DOs far too much in the system. The PAs and the nurses can do a lot more. And I mean, Jukka, you know a lot about that because you have been in a care setting, and of course, Sanjay, you have a very healthy view because many doctors say that I'm the only one who can give care, which is not at all right. And but to me, that matching is one of the key pieces, and focusing the time to the ones who need help, because we all know we need the doctor's words at times to make a change in our life.
Yeah, and if I can jump in, I think, Ari, that's really, really important. Multiple of those points were super important. The thing that strikes me is that we're going to look back on how we've been practicing medicine. I think in 5 years, 10 years, we're going to look back to this day and age over the last 10 to 15, 20 years, and we're just going to kind of hit our hand on our head and go, oh my gosh, I can't believe that's how it was for so long. This idea that there's a doctor's office and that the patient, when they're not feeling well, has to get to that office via appointment, via transportation, via waiting in the waiting room, via getting checked in and having their vitals checked, and then sitting there for longer. And then they get a very compressed amount of time with the provider, which feels very dissatisfactory to both parties involved. And then they leave, and there's this whole string of interactions that happens, which are also very broken around, reimbursement and copays and this whole black box of what insurance does or doesn't cover that nobody can tell us until you actually are faced with a bill. So the whole system is just really just laden with so much friction. And, I think we're going to look back and, we have so much data that we're all giving off at any given moment, right? So that my colleague and I love the work of Daniel Kraft, if anyone's followed him, but he talks about this digital exhaust that we're all giving off at any time. And our cars are getting better and better at harnessing all this data via sensors, and they're able to be smarter and smarter and sort of tell us, hey, I need this at this point in time. But we have that opportunity now with our bodies and with our healthcare to have different sensors, to have different wearables, to have our social media use aggregated into some kind of a dashboard that that shows here's what, our search history, all this data, all this, exhaust that we're giving off. We have the opportunity over time to put that into a smart system to, it has to be, it's such a vast amount of data that it's going to have to be run through, AI and ML and parsing that data, but then rising to the top, the signal that says, hey, that's the person, or those are the 5 people, to your point, Ari, that we need to reach out to, or to your point, Yuka. And that system will learn over time, because then the provider can be reacting in real time, the care team can be reacting in real time, deciding who's gonna, respond to that. Obviously, the chatbots are a great system once they get smarter and smarter and start learning these systems, but we can really start leveraging not only each individual's time within the system, but also the opportunity to have a visibility, to have a dashboard where we can see who is in greatest need and who's actually doing quite fine, right? So it's a really exciting time.
Yeah,
absolutely. By the way, sometimes we forget, by the way, that there are 1.2 billion visits to doctor office 2019, 1.2 billion. So think about, it's a very vast and big system, and it's very difficult to change overnight. I think all of us in the webinar today, we are frustrated about the fact that we are moving slowly. It's baby step after baby step, but it is just so big that you can't change it overnight.
Yeah, and I'd say, just to again kind of build on the exhaust, the data exhaust. So, not all data that a patient in a device, even if it's an analog scale, is relevant. And so, there has to be today, without the use of technology, a human has to look at that weight and say, is it relevant? And then what action do I need to take on it? And that action might be, okay, the patient had a 3 or 4 pound increase from yesterday's weight, and we're talking somebody who has is under monitoring. Maybe they're part of a panel view that the physician is monitoring there. So is that who is that has to call and say, hey, check your weight again. Did you have your shoes on? Did you have your clothes on? Have you had a bowel movement? Those type of things, right? Did you take it on a different scale? Those type of things, right? So then now if you take out the human intervention there, and you have some piece of software that the signal's coming in, so is it a clean signal? And then if it is, so then now we've got the weight, and then you have to apply logic. And then out of that logic, if everything has been placed, and it's almost like if then else rules, right? You can kind of follow the pattern here. Now it's like sitting there with Sanjay, and does he need to memorialize that in the record or not? And not everything that is reported has to be memorialized in the chart. So, we've kind of gotten a little bit over our heads with, bring your own device, just, hey, everybody should have, all these electronic devices and things like that, and just start flooding your doctor's, inbox, maybe through my chart. I mean, I know that a lot of patients, they love to just copy and paste a bunch of stuff into my chart and send it over to their doctor there. And, you can just imagine what that's like, the human on the other end that has to kind of look at that and say, what do I do with this? Mm-hmm. So I love the tech, but I also love that we still have analog. My scale is analog because it's very accurate and it works. But at the same point, if I'm reporting on my weight and I'm using, whether it's text or voice or video or an app or something else, then that has to have some type of filtering capability in there, so that the clinical operator on the other end isn't completely overwhelmed.
Yeah, and just to build on that for a quick sec, if people are reporting symptoms, any small misspelling of the word causes things to go into different bins in a database. And so we need to really continue to develop our ability to put things in the right section and have them be able to be parsed in such a way that the systems and the machine, the computer, can actually bundle things into the right bundle properly.
Yeah. Sanjay, there's something you mentioned that I wanted to go back to. You started talking about payment for services and technology, so that the physical setting is established to bill for services, in the virtual setting, that's still evolving. With the new technologies and the digital solutions that are coming in, certainly providers can't keep absorbing those costs. So what is your view on, and what are some of the challenges with the digital solution and the costs, and who should be paying for the new technologies and the costs of maintaining of those technologies? So Yuka or Sanjay, from a digital and a hybrid perspective, what's your view on paying for digital technologies or reimbursement?
Yeah, I mean, I think over time, the technology will prove itself out and will be, shown to be this hybrid model of the technology with the support will be, I mean, so to back up for a sec, the place where medicine really fails right now is in managing folks with chronic illnesses, right? Obviously, we do a great job. I had a skiing accident last January. I needed surgery. Like, my gosh, I'm so grateful for all those people, each and every one that touched my life that day and got me, in and out and back on my feet, literally, within a number of weeks, right? So, but chronic illness management is a huge, problem, and so I strongly believe, and I think all of us here today probably do, that it has to be some kind of reimagining of the system in order for it to work, and we have to lean on technology. We have to use all of the things that are out there and continue to evolve them. It will pay for itself like multiple times over once the system starts to recognize the value of it and the ability. In the meantime, it is very tricky, and these systems are expensive. Wearables are expensive, and there's a price to all of this. We have a unique position at our clinic, meaning that we're a direct-to-consumer clinic, and we position ourselves outside of the healthcare system. Has some benefits, obviously, has some downsides in the ability to bring that care to the larger population. But I think an important lesson there is that people, if they perceive value, are willing to invest in it, and they're willing to put their money forward and to support that care. And so the way we've been doing it is to build a membership model. So there's basically 3 different levels, and trying to make the lowest level very accessible, so that we try to include as many people as possible. But it includes the care, it includes some of the technology, it includes access to all of the data systems that we use. And the other thing that we've been looking at is to build out programs. So 4 weeks, 6 weeks, 8 weeks, up to about 6 months is our longest one, where we're leveraging the ability to put a lot of the content onto a learning management platform, have people watch that asynchronously, and then have group visits and have a weekly or every other week check-in with the provider, and then separate check-ins with the coaching staff or with the nutrition staff. And there's a lot of cool things that happen with that, because you can lower the cost point a lot by moving it to this asynchronous plus group setting. But then also you really start leveraging behavior change, the science of behavior change, and learning theory, because like we flood people with too much information in too short of a period of time, and it really helps them, I think, make sustainable change in these chronic illness models, to have that information coming at them in small bits, in a sort of a drip campaign model, with reinforcement, with discussion, with the ability to start making those lifestyle changes and experience it for themselves. And it takes a good number of weeks, 3 to 6 weeks, to have a successful habit change, right? So when you're asking people to change their sleep or their nutrition or their movement or their mindfulness, stress management, really helps to build that into longitudinal programs. So I see that as a huge ability to save cost over time.
Yeah, for us, obviously, given that our model right out of the gate was digital first, so having world-class tech is expensive, to whether it's AWS or Twilio or Slack or anything else out there. So we had to raise money. So we're venture backed and went through all of that cycles there. Sanjo makes a really good point around the direct to consumer, and so we've all seen ads, for quite often, primary care or some type of disease management company, and they're trying to appeal, direct to consumer. But that type of very incremental organic growth that's a slow crawl, especially if you've got big investments. You have investments, if you've got bricks and mortar, you got investments in your leases and things like that. You're paying a lot, especially in the Bay Area. It's premium real estate there, and then plus all the tech and everything that goes along, and staff and insurance and all the other things that goes into there. So, running a medical practice is expensive, and even on the digital side, even though we don't have physical buildings, our tech is expensive. We have clinicians. We have very expensive insurance. All of those type of things as well. So for us, we look at where can we get volume and velocity, and that's where we do direct to employer contracting as a provider, and then also through other health systems and payers in that sense. Very kind of the typical like medical group or IPA model where you're looking for high volume, and then out of that volume, then velocity of the volume that you can support out of those. And then with that, then is it fee for service or PMPM? PMPM tends to work best for us because we understand our costs, we understand what our margins have to be. And then also with the AI, we know how much of a lift the AI gives for urgent, emergent type of needs on the clinical side, and then how much of a lift does the AI give for more of the maintenance, type of things, which is about 70 to 75% of those transactions in the encounters. So you really need to understand, your business and the unit economics, and then also what can you live with, from a margin perspective, because you will get squeezed out there.
I think 2 quick points on this. I think you talked about really valuable elements. To be a bit of contrarian as I am, I think we spend about half the money today out of the 3.5 trillion into managing chronic conditions. And like Sandra said, we absolutely suck at it. We are really bad at it. We spend more than any other country in healthcare for managing stuff that we don't really do any value. Like we maybe expand lifespan a little bit, but really the value is limited. Why don't we take half of that money and spend it on preventive care before people get sick? That would be the biggest bet we could do, and it would have an impact. That's why I personally, my company at Elo Health, we have D2C model, like Jukka said, direct to consumer. We are VC funded, so we can probably invest quite a bit in the beginning on AI, on the different tools we do. But we are basically focusing on providing people the right nutrition at home that can help them to stay healthy or get healthy and so forth. But maybe the bigger point even is that today we are in the beginning of the digitalization, in a sense, in healthcare. You have the S curve where you go into the S, into the kind of vertical S, like automotive has gone recently and banking did in the last years. What happened is that million people were displaced who were tellers in banks. Million people were working in travel, in booking and travel agents and stuff like that. They are not there anymore. We don't have a vaccine at healthcare to be immune to this. We are in the beginning of the chasm, and 10 years from today we can go back and talk about this, and all of the stuff we talk today will seem like dabbling the kind of the edges. There will be fundamental things that will change, and I think a lot of people will get paid less, not more. So telemedicine, these things, it's hard to see that you're going to pay $250 a visit that takes 15 minutes. I don't see that happening anytime soon. And the price structure for telemedicine was defined by D2C companies where people were not reimbursed. And it got around $50 to $40 a visit or whatever. And that will become the norm. And there's no math you can do to earn $250 a visit in the new world. You better make more visits or do something else. And that's a fact of life. People need to realize it.
It's a really interesting discussion, and we have lots of commentary and a few questions, which I do want to get to. A couple of questions that we have gotten are around the consumers transitioning to digital interactions. So we've been talking about physicians and tools and digital interactions. what about consumer adoption of digital tools? Because we see TV and social media ads for new provider practices or technology-based provider practices, which, as you mentioned, per member per month fee with lots of tech, and they're pitched as highly optimized, consumer friendly, using tools and text for communication. So first of all, how do you address the consumer, the challenge of communicating with the consumers, and does that help you strengthen the provider brand?
Yeah, I mean, I think it is a challenge, but honestly, there's a bell curve, right? Of like who's adopting technology and when, and we are pretty rapidly, moving to the point where many, if not most people are pretty comfortable with technology. And I love just seeing the evolution of our smartphones and, web portals and, apps. I think that they're more and more user-friendly and they're more and more accessible. And, even my parents who are in their, late 70s, early 80s, they're all over it. They're texting, they're using Facebook, they're using different chat apps. They're pretty comfortable, navigating that ecosystem. And so I think that, companies like Joseki and Elo, really are doing an awesome job of making it easy, right? So I think there really doesn't need to be a barrier. Sure, there's some who are, really reluctant, and we do have to do some hand holding on that for folks. There's another discussion around various levels of disability, vision or hearing, et cetera, that makes things more challenging. So we have to keep that in mind. But I think, there's no going back at this point. And if there's some silver lining that's come from the last couple of years of COVID, it's how aggressively and quickly it's pushed a lot of this forward. And I think, we've always been at the California Center for Functional Medicine, always been passionate about this mix that we're talking about of personal touch along with technology. And so it's a deep part of our brand, and it's a deep part of how we differentiate ourselves in terms of providing excellent information and knowledgeable physician support, but also that technology link. And I don't really see how health systems or providers are going to remain relevant unless they really start moving into this area and start pushing their use of these different mix of technologies and care.
Yeah, we as the industry, we need to stop talking about patients and members and talk about consumers, and accept the fact that the consumer is basically pulling the industry of healthcare into the new world. And this industry is screaming and kicking and being like a baby about it. So I think the dice is already cast, and the people are ready to adopt. Everybody has a smartphone. Everybody is a savvy customer. And I think we at Healthcare, we're the last bastion who is not there yet, together with the government. So we have to move and provide people what they already want and get elsewhere.
Yeah, when we launched Joseki in 2016, we think we were the first healthcare provider to actually launch on Facebook, and it was an experiment. Part of that experiment was can we convert a stranger to a friend, and then from a friend to a non-paying customer at first. We actually gave free care to them. Especially for a name that no one had ever heard about, probably hard to pronounce, and not affiliated with some other brand, that people are more familiar from a healthcare perspective out there. We actually acquired about 500,000, just shy of 500,000 customers through that experiment, and we learned a lot, from them. And so, for me as a clinician, I was taught early in I think probably back in my school, was just to introduce myself, and then just say, how can I help? And so it was amazing, that experience was when I was the clinician behind Joseki, and we had people interacting with us, and I'd ask, they received a text from me, how can I help? After I introduced, who I am. And now what I'm super excited about is our data shows that within 5 months of bringing on a new customer, and they're getting used to the interaction, it's a hockey stick curve. And we have about a 34 to 38% engagement, continuous engagement with our patients. So we know that something's working there. Whereas when you look at data for other health systems and like bricks and mortar, it's much lower than that, often in single digit. And our NPS, our most recent NPS that we calculated is 78. So awesome. We actually went from 72 to 78. Yeah, and that's like world class. You can Google out there and try and find, what other non-healthcare companies are above 70, and try and find a healthcare company that's anywhere near and close. So it's not just attributed to the tech. It's attributed to the hybrid model. So the tech and the humans behind there that really are caring, and they show that they care. And when we all learned about when we started using email back in the dark ages, we learned about email has tone, right? Remember that? And even like part of that tone is like, were you emailing, or did you email, or did you text when you were angry, right? And so we work really hard at trying to be calm, and the way we're communicating with our patients as consumers, that it's done in a way that we would want to be treated, the golden rule, in that sense.
Yeah, your point, Yuka, around the hybrid model and the NPS, not to toot our own horn, but we're right there with you guys, and something that we're really proud of being, again, the hybrid model, but providing direct medical care to patients. We've been tracking our NPS for a couple of years, and we report it to our team every Friday, and it's pretty consistently right at 76. So awesome. That feels really good, and I think that it's just this was what has to happen for folks. So
excellent. We have a question from one of our attendees. What do you think of the potential of blockchain technology, in addition to the tools that you've already discussed, and in addition to AI and NLP? Specifically for helping people have a longitudinal record of their wellness. Thoughts on that?
I think maybe I could start.
Yeah.
I think there are a few elements in healthcare that are very, very good for the blockchain. And I think storing the personal health data is one. Another one is storing a record about a provider, for example, who they are, where they are they good, whatever, so you can match better. Those are both really excellent use cases. I think the challenge with the data about your health in blockchain today is that the file becomes quite big. And if you think about the blockchain today, it can be quite slow. So even with the Ethereum, it hardly can process or store data effectively today, because a lot of the data about us is starting to be video, and any type of imaging, it just becomes terabytes of data quite quickly, and that I don't know if it's possible today to do in any type of blockchain today, because keep in mind it's going to be distributed, so you don't want to have terabytes of data in all this different blocks, but it could be done in different ways. And definitely if you take like immunization data, for example, for the COVID vaccine, I hope, well, there are already a few companies working on that, and I hope we can adopt something like that for critical things like knowing that I'm vaccinated. You maybe hear what happens in New York right now. They're thinking about making it mandatory to have a vaccine to enter A and B and C. If it happens, better be a good system that is bulletproof.
Yeah, Ari or Yuka or Sophia, what's your guys' finger on the pulse with regards to blockchain and healthcare? Because about 3 or 4 years ago, I love going to the tech conferences. I try to go to Health 2.0, for example. I mean, 4 years ago, the entire conference was all about blockchain, and it was just everyone was like, blockchain is going to be the next greatest thing for this and that, and everything involved with the whole, all the different layers of healthcare. But that I've seen that really die down. That discussion has really quieted down. And so I'm just curious, what's your take on and Ari, you bring up some of the complexities, but is there a really active, what is that? What's the state of the state with that discussion right now?
I think, for us, because, everything begins with us and it kind of ends with us, as just with you as a medical practice. So having that, almost like that traceability or the visibility of what I call the data journey, it's important, so if we refer a patient, for lab testing, right? And then that patient also gets referred to, something else out there. And then there's someone that wants to kind of see the whole, journey of the data. Do you need blockchain for that? What's the use case? And I think that just in my opinion, we as healthcare, we tend to get really excited about buzzwords and technologies that are being used outside of healthcare, because healthcare can be so slow to adopt, certain type of technologies, particularly those that are used like in fintech, and also in manufacturing. So, we get the groupies that start to use those, those terms, but, have we really kind of put any effort into the discovery, right? And as we know, that takes time and money and resources, to do discovery. And part of that discovery is, okay, if this is a new way of doing things, a know-how or a technology, how are we going to use it? What's the use case or the use cases for that? And then are those use cases applicable to us? And then if they are they so applicable that then there's a business case for adopting this or applying this technology, because there's going to be a cost to it. And once you pull the trigger on that, then there's a support and maintenance cost. So I think I totally agree with you. I think that people are just running around like, oh yeah, we're doing blockchain and all this type of stuff. But, had they really done the discovery and developed the use cases and then the business case supporting them? I'm not in any hurry, from our perspective to start applying it. We're still in that observation mode, but, for a company like ours to do the discovery, then I'm pulling people out of, other day jobs and everything to do the work.
I think we can probably,
you are still kind of in this, so at this point, again, we think about the adoption curve. The hype cycle comes first, then we go down. And when we all are thinking that, oh, it died down, then suddenly it will explode, because there are, hundreds of teams working in the US today and globally even more on deploying blockchain in healthcare. And there are big companies like United Healthcare, Humana, and others who are deploying teams to work on it. So it's percolating there, looking for the right application, and we'll see it in a few years. And I think it will become quite big and quite important in healthcare.
I wanted to thank all of our participants for joining, and I'd love to thank our panelists. I think we can probably continue this conversation for the next hour or two. However, we are a little bit over our time, and I want to respect everyone's time. I do think we can continue our conversation. I've just pasted the link to our LinkedIn page for Northern California HIMSS, and specifically for this event. We can continue the conversation there. Please post your comments and questions. We will also post a link to the recording of this session, should you wish to share with your colleagues or listen again to any points that you particularly are interested in. We look forward to you joining us for our next discussion, and thank you to Jukka, Sanjay, and Ari for joining us. We really appreciate it. I very much enjoyed the discussion. I hope you did as well.
Thank you.
Thank you.
Thanks very much.
Moderation.